In a brief few months, technology has shifted the way we all experience healthcare. My next two guests are on the cutting edge of new treatments and technologies that are revolutionizing patient care for those with diabetes. Dr. Robert Lash is the interim CEO of the Endocrine Society, where he leads initiatives designed to make scientific breakthroughs a reality. Sounds like my kind of guy. And Dr. Satish Garg is a professor of medicine and pediatrics at the University of Colorado. He researches novel methods of insulin delivery and innovations such as continuous glucose monitors. So I'm looking for a very cool technology conversation on how we're changing. So let me just ask you, Dr. Lash, I asked Dr. Peters this, what's coming down the pike that we should know about that may change the very terms that we think about this problem?
Well, there's all kinds of technology that's being used to help treat patients with diabetes, but the one that's come to light in the past few months since the advent of COVID really has been telemedicine. Telemedicine has made such a big difference in the lives of so many people with diabetes, along with several other diseases, of course. But the idea that you can take care of a patient through telehealth and be able to look at their blood sugars, discuss their clinical situation, and help them make decisions about improving their lives and their health has been an unexpected big advance that we have seen, probably one of the few good things to come from the past few months. My hope is that we'll be able to continue using telemedicine as a way of meeting with our patients after the public health emergency is over, and that insurance companies, both at the federal level and among the private insurers, will continue to pay for telehealth visits just as they do for in-person visits.
Let me just ask you before I jump to Dr. Garg, why are we, I know why we are talking about this because it wasn't covered before. We had a crisis. But let me just ask you, people seem to be loving the telehealth experiment. I don't know if that's true of every single person out there, but it just seems that many times I've been discussing this and thinking about rollback, and I've talked to many members of Congress on this, it just seems unfathomable that we would go back. But is there a risk of going back to a time when telemedicine was not paid for?
It's a great question. Based on the success that we've had, it's hard to imagine that we would go back. But there is certainly some resistance to paying for a visit when the visit is not in person. And there's this feeling that unless the provider and the patient are in the same room at the same time, and there's handshaking, which of course we wouldn't do now anyway, and a physical exam, that it's not really a visit. And what we're seeing is that's not the case at all. You can provide superb health care for the vast majority of patients in a telehealth environment. And now that we've seen that it works, I think it's going to be really hard to put this genie back in the bottle. And I hope you're right about that.
I want to hear Dr. Garg's views of this, but I mean, it reminds me of these old trade debates 30 years ago. Is a book, or is it a bunch of digits and data that's sent over the wire? And right. Should you have to pay for the same thing, for a book? I mean, it just sounds like this antiquated debate that we've already had in other areas. But Dr. Garg, I want to hear about insulin delivery, but I want to get your thoughts too on telemedicine and where we've gone and how that's figured into your picture of the diabetes treatment scene.
So at the Barbara Davis Center for Diabetes at the University of Colorado, Denver, just like all the rest of the US, we went through lockdown. But now for the past 2.5 months, we have done both joint telehealth as well as in-person visits. In-person visits all started in June. But the telehealth has been a welcome change, specifically when all the limits and all the extensions were given by the government. For example, we could practice medicine from one to another state. At the Barbara Davis Center, Steve, we have 20% of our patients come from out of state in person. And now we were able to provide them telehealth care when they're in Nebraska, Kansas City, New York, and what have you. And that, I believe, is going to go away. And he's absolutely right. Genie's out of the box. I think we have to find a way to make it available going forward. Otherwise, patients are not going to like coming in person. My fear is, just like Aetna, starting on June 4th, they stopped paying for the telehealth. And many other insurance companies are stopping the expanded coverage, most of them ending in August or the September. And I think there needs to be an attempt made to see if these can be expanded, whether it's on a limited basis or on an expanded basis. We know that most of the diabetes care can be done through telehealth. At least 3 of the 4 visits a year can be easily done through the telehealth.
Right, Dr. Garg, I also know that you've been experimenting with insulin delivery innovations. What are the patient? I mean, I'd like to hear just a little bit about that, but also, what is this? This patient that we're talking about today. This human being has diabetes. We're in a pandemic that could kill them easily. What are the other elements of the ecosystem that we need to think about that we're not aware of for that individual?
So, Steve, what has really helped us the most during the pandemic is the availability freely of continuous glucose monitors. That has truly revolutionized the care for people. Through the iCloud, we can look at all their data in real time. For example, with the Dexcom sensor, in the past, there was a 3 hours delay. I had to talk to the FDA when I was doing new onset management in March and April. They still had the 3 hours delay. When I talked to Courtney at the FDA and I said, Courtney, this makes no sense. I'm the provider. I need to see data real time. I don't care what rules you have. And she took an amazing step, and now there is no delay in any of the devices, whether it's Libre or it's Dexcom, all of them are real time. That facilitates better outcomes. And not only that, with the availability through iCloud, I can look at the data when I'm doing the telehealth. And that allows us to improve the outcomes extremely well. The second thing which has really helped during the pandemic is most of the sensors, whether it's Libre or it's the Dexcom, can be easily used through a simple YouTube video. They can use it themselves. They can learn how to use it. It literally takes 5 minutes. And number 3, we have learned now how to implement new insulin delivery devices, specifically insulin pumps or the new insulin pens, using remotely through a YouTube, so that all the companies, Medtronic, Tandem, all the pump companies have created vehicles that people can learn and electronically start these devices. And leave alone, there is also an alternate way to deliver insulin, like the inhaled insulin or the pulmonary insulin. The only one available is Afrezza. That has really facilitated patients' improved outcomes.
Let me ask Dr. Lash a question, and we've got a question for both of you from our audience, which I'm excited about. But Dr. Lash, I'm sort of interested in this picture of the Endocrine Society and how you're responding to these times and changes. And I'm always interested in how your own purview of this has changed the course you're going, how you're thinking about inclusion of different populations in this in new ways. And again, I'm probably, I mentioned this too many things. I think there are a lot of earnest people that deliberate and kind of move in a linear way. Are you finding any bank shots out there, any accidental discoveries that will make this all a much easier topic? So, Dr. Lash?
Well, that's a great question. And when all of this started, we were very concerned about the inability to meet with policymakers, to meet with legislators, to meet with people like Representatives DeGette and Reed, and talk to them about what's going on in the world of diabetes. What we've discovered is that the same virtual world that's helping all of us have Zoom meetings with our family and our friends and our business colleagues and being able to work from home is also able to help us support policies and advocate for people with diabetes. two of the programs, one program in particular, where we've been really concerned about having a continuous, the special diabetes program. The special diabetes program supports type 1 research at NIH. It supports care for type 2 diabetes, including Native Americans. It also is one of the major programs that lets us advance the work of diabetes through NIDDK. The program is set to expire. It needs to be extended. It's a long-standing program, and our ability to advocate virtually for SDP has been an unexpected benefit from having to stay at home all the time and do all our work through Zoom.
Well, cool. I always need more time for these discussions. We have a question for both of you from Sean. Sean?
My name is Sean DaCosta, and I am living with type 2 diabetes, and I am a Livongo member. My question is, given the increase of telehealth and remote monitoring due to the COVID-19 pandemic, what role will consumer-directed virtual care play beyond the pandemic?
With Dr. Garg.
Yes, the consumers should play an immense role from two angles. One, they will see definitely better outcomes. They'll get empowered by using these tools to improve their outcomes. But more importantly, can they also emphasize the importance of this telehealth, whether you're using Livongo or any other vehicles? And they also empower the insurance companies and the payers to continue to pay, just like Medicare, Medicaid, and across the different states of the United States. So I personally think the consumers will play a very important role. We need their voice. Without their voice, I don't think the payers are going to listen to us, because they will say, well, we are the party who is going to benefit as, as the providers. Thus, I think consumers need to be part of the discussion.
Robert?
I think Satish has covered that topic extraordinarily well. I agree with everything he says. I would only add that there's an adage in the management of diseases like diabetes that the patient is often the doctor and the doctor is often just the coach. And when you have a disease like diabetes, patients need to be able to make important decisions about the kind of care they get, where they get their care, and the medications that they use to treat their disorders. So I couldn't agree more. I think having patients play a major role in directing their care is only going to help everybody.
Look, I'm going to violate my schedule for just a moment because you've both made me think of like one last little question. I kind of make these forums all about me. But my question is, when you think about telehealth and telemedicine, before that era, one of the challenges that we had out there in healthcare was the accuracy of diagnosis. And if you look at the onset of technology and new calipers, new ways to look at these things, new machines that are attached to us, new ways of processing data, I assume that diagnostic level of accuracy is going up. Am I right? And is telemedicine in a way, when you talk about the data that you were just talking about, Dr. Garg, am I correct that we're seeing greater accuracy rise? And we almost never discuss it because we don't want to admit all the failures in the past. But tell me where I'm wrong if I'm wrong. Dr. Garg?
No, you're absolutely right, Steve. When you look at the continuous glucose monitoring data, you're looking at glucose data, though monitored subcutaneously every 5 minutes. And thus, you can look at the glucose trends. Indirectly, yes, you don't have A1C, but you can have an estimated A1C, which pretty much gives you. But there is another metric that we have clearly shown, time in range, which is glucose values between 70 to 180 that quantifies what is the likelihood that the patient is going to be in good glucose control. Plus, on top of that, it gives you time below range, which is hypoglycemia, or time above range, which you can adjust, whether it's above 140, 180, or above 250. That gives you different metrics. And above and beyond There is another indicator called Glucose Management Index, GMI.
Right.
So these are other tools that continuous glucose monitor data provides you other than an A1C, which has its own fallacy in terms of its accuracy. So I think these new tools allow you to monitor diabetes more effectively.
Dr. Lash, let me give you 30 seconds.
Okay, thank you. You're right. The ability to diagnose diseases over telehealth is going to have a major impact in healthcare. Whether it's somebody who can get on a scale and you can tell them whether their heart failure is getting better or worse, who can measure their blood pressure, who can send an EKG, our ability to work at a distance, to work virtually, and to work with new diagnostic tools that can talk to the internet is going to improve the health of people, not only with diabetes, but with many other diseases as well.
Well, thank you to both of you, Dr. Robert Lash of the Endocrine Society, Dr. Satish Garg of the Barbara Davis Center for Diabetes at the University of Colorado. I'm sure it's really beautiful there, too. Thank you both for taking us on this journey with us as we talk about these important issues. We're going to have a couple members of Congress on. One of them is co-chair of the Problem Solvers Caucus in Congress. I love that group. I feel like we have problem solvers doctors out there, and I'm going to make you both the heads of it. So thank you so much for joining us today.
Thank you, Steve.
Thank you.
Thank you very much.